Hello and welcome to this episode of the Brain Train channel. Before I move on to the recording with our guest on this episode, I would be very grateful if you can firstly, number one, subscribe. That helps alert you to new content when it's released. Two, like the video. I've been reliably informed by YouTubers that liking videos helps with algorithms, whatever that means, and ultimately can get this helpful content pushed out there and get the information out to others who may find this helpful or are affected by acquired brain injury. So I appreciate everyone who watch on YouTube says that, but I can say on this occasion it is obviously for good, charitable and educational reasons. So at the end of each episode, I will have a signpost to other pods, vlogs and websites and contents from around the brain injury world, which you can access and hopefully gain more from. So without further ado, I hope you find this episode helpful and informative, and please do leave comments and feedback in the box below.
Hello and welcome to this first episode of the Brain Train channel. I'm delighted to have as our guest today Dr. Ruth Kent. Ruth is a consultant in neurological rehabilitation at Pinderfields General Hospital and a senior lecturer at the academic unit of rehabilitation medicine at the University of Leeds. Ruth also somehow manages to fit in medico-legal expert work as well to assist instructing lawyers as to the nature of a claimant's brain injury and what their rehabilitation needs are. So Ruth is here today to explain the basics about brain function, along with what happens when the brain is damaged through trauma. Today's episode should hopefully serve as an introduction to the brain. And as the channel and series progresses, we will, of course, be looking at certain things concerning brain injury in more detail. So without much further ado, let me bring on Ruth. And it's lovely to have you on, Ruth. So why don't we start with, well, how did you end up becoming a consultant in neuro rehab?
Oh, well, good morning. Thank you very much for inviting me. I sort of took a route to being a neuro rehab consultant. It's not a specialty that people know very much about. And I was very fortunate, I think, to train in Newcastle, where my mentor, Professor Mike Barnes, was working. And he was very active in developing the profession and the specialty. So I had a really good opportunity to participate in a training program there, which was really good. Essentially, I did basic medical training. I did a intercalated degree as an undergraduate, looking at cerebral palsy. And I thought I'd probably end up doing pediatric neurology, cerebral palsy, pediatric neurodisability, but I ended up doing general adult medicine, where I did a registrar rotation in medicine and did all the right things to get my hospital doctor's exams. And then I went in to do this as a research registrar initially, and then an old senior registrar who became a specialist registrar. And the specialty itself is called rehabilitation medicine. And it's important, I think, that we call ourselves neurorehabilitation because it describes what we do. But within the profession, we're very fortunate in that we have a very broad training. We train not only in neurodisability, and I was fortunate to do quite a lot of neurology and stroke along the way. So I felt I got a really good grounding in those areas. But also we do mandatory specialties in musculoskeletal medicine, in spinal injuries, and we also learn about amputees. So we get quite a holistic view of disability. So it was a good fit for me. It was a good fit for my personality and my interest. I think reflecting back, older in life, I thought, well, what attracted me in the first place? And I think I was aware that my father had disability from a brain hemorrhage at the age of 18 and was left disabled, but fulfilled all his role as a parent and a worker and what have you, but actually fought all the battles right back in the day. And I think that's probably was an influence. My mother taught deaf children, and I spent a lot of time with disabled people and places like the Deaf Club. So I felt very comfortable working in this area and feel it's an area that's been very underrepresented and under advocated for. Sad to say, I think medicine is quite a strange profession in that there's certain things that are considered to be very prestigious, things that are very acute or very clever. But actually, the reality of my day-to-day work is around helping people to understand their conditions, diagnosing the exact nature of their conditions, understanding what is constituting somebody's disability, and also to help people manage their symptoms, particularly pain, spasticity, urology symptoms, all different sorts of symptoms. And I think because we have this broad brush training, we're able to be a bit of a one-stop shop to people who feel they're bouncing around between different specialties. So particularly my work with people with cerebral palsy, for example, which acquired brain injury at work, I feel I can offer quite a holistic approach to it. So it definitely suits me anyway and my personality.
Yeah, no, I think it's always good to start with just for people to understand how you get into the role that you are doing, because it's not just the brain injury that they've got. There's often orthopedic injuries that come with it, and there's a whole mixed bag of things there that need to be looked at. So that was really helpful, Ruth. Thank you. What I was just doing whilst you were speaking there is just I'm going to bring up a diagram of the brain, because what I'd like you to do is just explain the different areas of the brain and what they're responsible for in terms of functioning. So if you just bear with me, and through my IT skills, I should hopefully bring that up for us. If you can see that, Ruth?
Yeah.
Perfect. Okay, so I'll hand over to you to just sort of explain the different parts that are going on there.
Well, let's talk about the brain as a whole to begin with. The brain itself is important that it's connected, and lots of areas are connected. We talk about functional localization of areas of the brain, and this goes back to some of the early studies that go back almost as far as the First World War, and then were consolidated in the 50s, where people had epilepsy surgery and a certain wire would be put into a certain place and a certain function would be lost or changed, and people realized there were certain areas of localization, and people realized that certain symptoms could arise from certain areas of localization. What I will say about brain injuries per se is sometimes it's not as simple as that, and multiple areas are damaged, or there are areas of the brain which connect to other parts of the brain that can be imaged, and they can be damaged in such a way that they affect the relays between the different parts of the brain. First of all, we start about the hindbrain, if you like, which is the back of the brain. This is the stuff that we share with the reptiles, and we have basic, what they call vegetative functions, which keep our brain going. We have control of our blood pressure, we have control of our respiratory rate, we have control of our basic physiological functions. And if those parts of the brain don't work, somebody is essentially brain dead. And that can happen in a situation where perhaps the brain becomes irrevocably damaged, or the brain swells such that that area of the brain becomes compressed. And that's obviously a very serious matter. Then we have areas around the brainstem, which are really important. And again, these can be affected. We talk about the pons and the medulla. We have things like the nuclei of the cranial nerves. We have areas where the various tracts from the higher parts of the brain meet, cross over, and receive connections from other parts of the brain. And again, we might see damage to the brain in those areas. Say if somebody has, again, had a swelling to an area of a brain. There are one or two quite unusual symptoms, or usual syndromes, should I say, which, for example, with locked-in syndrome, somebody might have a very specific area of damage to that part of the brain, such that they lose the blood supply, for example, in a stroke to the basilar artery, for example. And those areas that would cause what they call locked-in syndrome, in that some of the fibers from the upper part of the brain would all be intact, but somebody may not be able to move. And that's quite unusual. It's rarer than it ever was, but it does exist. And it's an area which has caused quite a lot of interest, because I think it's a very, very quite scary sort of phenomenon that somebody can imagine. We talk about things like the cerebellum. The cerebellum, again, is very well developed in certain animals that move fast and control their movement. And a lot of our cerebellar function is around coordination and balance. If you get drunk, for example, your cerebellum isn't working correctly. And that means that the area in the middle, the vermis, may not be working, and people can have lesions either in the middle of the cerebellum or the two arms of the cerebellum, and that can lead to various issues with regards to balance. But interestingly enough, the cerebellum in recent years, we've started to appreciate that it's not just about balance and control of movement, but it's balance and control of emotion and balance and control of thoughts. So that's a bit of area that's not well known or well recognized. And it's really important, because the cerebellum is like a little mini brain that, if you like, plans activities, organizes activities, and helps the brain to plan what it's about to do, so we can do everything in real life. So we talk about the occipital lobe, and that is, if you like, the big visual cortex. The visual cortex is obviously really important, and somebody can have a deficit in their vision arising from damage to the occipital lobe. The thing that's different from blindness or loss of vision in the eye itself, the retina, or any of the more frontal connections of the visual system, is that you can lose half of the visual field. And a typical homonymous hemianopia, which is half of the two fields of vision, i.e. half on this side and half on this side, is a typical lesion of the occipital lobe. And generally, by the pattern of deficit of somebody's visual field, it can be localized as to where the area of damage is. Talking about things like the parietal lobe, lots of areas to do with sensation and feedback, proprioception, sensation, and we go into talking about the motor areas of the brain, again into the front part of the frontal lobe and the parietal lobe, and we start to talk about control of movements. Because the tracks from these higher areas of the brains cross over in the medulla, we know that damage to the left side of the brain affects the right side of the body, and vice versa. And again, we need to be just mindful of the fact that somebody can have a very localized lesion, or they can have a more large area. Typical areas of damage can be associated with, for example, strokes, for example, where the blood supply to the whole anterior part of the brain on one side can be affected. They typically, the middle cerebral artery is an example of a blood vessel that would be occluded in a severe stroke called a total anterior cerebral infarction. So typically those areas would cause damage to the motor system, for example, a hemiparesis. So you may see that in somebody with a brain injury. You don't always, actually, because it depends on the severity of the injury. And that's why I think I would focus very much on the frontal lobe of the brain when I'm talking about brain injuries, because those are the areas which I think are the most important. Up to the 1950s, 1960s, even into the 1970s, people talked about these being silent areas, and people routinely underwent neurosurgery, including operations like lobotomies, which were thought to cure various disorders, including intractable depression. So again, these areas are more respected now than I think they ever were. The interesting thing about the frontal lobes of the brain is the actual functional localization is less precise than various other parts of the brain, whereas in the parietal lobe you can pick the bit that controls the fingers or the wrist or what have you. In the frontal lobe of the brain, there are a lot of complexity, and a lot of the recent work that is done on the frontal lobes has been using techniques such as a functional MRI scan, which is quite a complicated research tool, which actually puts somebody through a particular cognitive tasks and looks at the activation in parts of the frontal lobe. But the frontal lobes are the areas of the brain which are the largest part of the brain. They are probably the most sophisticated, certainly in human beings compared to the other great apes. They are increasingly developed, and they're probably very important in a lot of functions, including the control and motivation of other functions. So it's really important, I think, to consider the frontal lobes when considering brain injury. There are particular areas of the frontal lobes which are important. We look at areas towards the back of the frontal lobes, looking at areas such as initiation and motivation. And we look at areas immediately above the orbits, which are important in behavioural regulation and behavioural control. And there are certain behaviours, particularly disinhibited behaviours, that can be specifically associated with damage to that area. And if somebody has had an injury where that particular area is affected, it can be very clearly demonstrated in terms of alteration in behaviour and personality. So it is quite interesting that these areas, although they are considered to be relatively quiet areas in that they don't control motor function, indeed, it's perfectly possible to have a relatively preserved intellect and have damage to these areas. But the fundamental change in the personality, the behavior, the ability to focus and switch attention, the ability to cope with distractions can all be affected. Interestingly enough, I think there are developments in research looking at the role of the frontal lobe in mental illness. And again, I think this is one of the areas where we make a very artificial distinction between the anatomy of the brain and the function of the brain, and actually really the difference between what we define as mental illness and what we define as brain injury actually is far more blurred than we give ourselves credit for. For example, in people who've had schizophrenia for many years, they can develop cognitive impairment, and burnt out schizophrenia can be associated with significant frontal lobe reduction in function. Similarly, there's a lot of interest in functioning of certain parts of the brain in things like personality disorders. So it isn't as straightforward as perhaps we would say. The temporal lobes are really interesting. They are frequently damaged in people with brain injuries, generally because they are in a very tight part of the skull where the brain travels within the skull during an injury, and the very frontal pole of it can actually get damaged by a piece of skull that tends to be pointed, and you can get focal hemorrhages into these areas. These can affect elements of language and memory. And finally, just thinking about the deeper areas of the brain, we talk about the basal ganglia, which are a series of areas which are involved in initiation and control and smooth control of movements, typically affected in conditions such as Parkinson's or indeed in chorea. They can affect the control of movements. And again, people with hypoxic brain injury, for example, somebody with an athetoid cerebral palsy, may have reasonable strength, but their ability to control their movement is affected by damage to these areas of the brain. Interestingly, as well, there is a strong role of these areas in emotional processing. And again, brain injury per se can be associated with difficulties in the control of emotions that are directly related to the organic brain injury. So if you like, the anatomy of the brain, which I have probably glossed over, and there are probably anatomists out there who would probably go into more detail or even correct me on some of these points, but I think it's important to think about functional localization, but it's also really important to recognize that the situation is probably a little bit more complicated than this, and certainly very severe brain injuries, for example, what they call diffuse axonal injury, that is an area where multiple connections are affected, particularly between the frontal lobes and other parts of the brain.
Yeah, that's certainly something I want to ask of you in a little while. Just whilst we've still got this diagram up, there was that little sac there, the pituitary gland. I did wonder whether you just wanted to briefly mention about
that
function.
absolutely. Let me talk about. So, I mean, basically, our endocrine system is run through a series of anatomical structures. We have something called the hypothalamus that releases various chemical messages that cause us to release to stimulate the pituitary gland. The pituitary gland has an anterior part of it and a posterior part of it. The anterior part of it is associated with a lot of our hormones that will stimulate other parts of the body. For example, in terms of our reproducing hormones, so you might produce LH and FSH, luteinizing hormone and follicular stimulating hormone, which will stimulate the ovaries, which will cause estrogen to be made, or similarly with regards to testosterone in the testes. There are the steroid, the ACTH, which again stimulates the adrenal glands to produce cortisol. We have thyroid stimulating hormone, which will stimulate the thyroid to produce these areas. So the thing that is very important is that if certain areas of the brain are damaged, particularly with extensive brain injury, and the pituitary gland is affected and not working effectively, this can lead to deficiencies in effector hormones. Fortunately, most hormones can be adequately replaced, so it's absolutely not a deal breaker, and I think there's a lot of legal cases I come across where people overthink this, that they say, oh, shall we get an endocrinology opinion? And I say, no, get the GP to do some blood tests.
Yeah.
Simple things are simple. And I think, what the message would be is it's very common to have symptoms such as tiredness or lethargy after a brain injury. But if these are persistent, then a simple test of pituitary function would be extremely wise, straightforward, simple, inexpensive, and easily fixed. There is a hormone called growth hormone, which is very important in children, obviously. The role in adults is not particularly well regulated or understood, but there are children who have growth hormone replacement if it is subtherapeutic due to the pituitary gland damage. Just for completeness, the posterior part of the pituitary gland controls a hormone called antidiuretic hormone, which makes sure that you don't just wee out everything and you retain your water. As a land-based animal, that's pretty important. It also produces something called oxytocin, which is important in lactation, but is also important in attachment and pleasure and various other things. So all quite important for well-being, to make sure somebody's pituitary gland is working well. And what's more, it's simple.
No, because I think you touched upon earlier about there's a certain part of the brain which is a bit bony, and when there is trauma, it can cause damage. And I think from my knowledge, that's where the pituitary gland sits. It's in that sort of bony, sharp bit of the skull, and it can get easily damaged there. I think the next bit I want to sort of try and break down for our viewers and listeners was just sort of explain the sort of different types of damage, because often when they'll read doctor's notes or have the doctor explain to them what's happened on the brain, they'll hear terms such as subdural hematomas, subgaleal hematomas, these very sort of technical medical diagnoses. And I just wonder if you can just sort of break down
let's imagine that you've got your two layers of the brain, the meninges of the coverings of the brain. Basically, you could have just a lump on your scalp, or a lump or an area of bleeding around the eye, which may cause some compression, but it's essentially outside the skull. Within the skull, the extradural or epidural hematoma is generally caused by bleeding of the middle meningeal artery, and it's a typical cricket ball injury where somebody's hit on the head with a cricket ball, they break the skull, they bleed from this artery. It's a rapid bleed, and this is what the golden hour is about, getting people into surgery quickly so it can be relieved. And people have lost their lives through an extradural, but if it's treated promptly and effectively, potentially people can do quite well, because the pressure damage is relieved quickly enough not to do generalized damage. We have a subarachnoid hemorrhage. There are two sorts of subarachnoid hemorrhages, if you like. There are what they call traumatic subarachnoid hemorrhage, which is between the two layers, and that's very, very common indeed, even in people who have relatively good outcomes, but they can have bleeding in that area early on. And then you can have a spontaneous or aneurysmal subarachnoid hemorrhage, which is caused by bleeding from a damaged blood vessel. And that's perhaps something you won't come across quite so much, although you sometimes come across it in clin neg work when somebody has what they call a sentinel bleed, in that they have a little bleed from an aneurysm. And they do well, it's not picked up, and they come back and have a serious bleed. And if the bleeding point can be identified, and repaired, the person can do extremely well. So you might come across that. Subdural hematomas are below the meninges. They tend to be bleeding from the veins that arch between the meninges and the brain tissue, because basically blood comes into the brain through the arteries. They form a circuit called the circle of Willis, and they serve the various parts of the brain, and then the venous system tends to drain through the venous sinuses in the brain. So, if you like, the circulation of the brain is a little bit different to other parts of the body. And also we have something called cerebral spinal fluid, which also brings various nutrients, etc., to the brain. So subdural hematomas are really common in elderly people, because if your brain's already shrunk, if you're elderly, or if you've had a long history of alcohol consumption, you may have a slightly shrunken brain. Paradoxically, this is a group where if they're treated promptly and quickly, they can do extremely well, because fundamentally what happens is that they're able to have the pressure relieved before it causes any major damage, and they can do extremely well. On the other hand, they can do quite badly, because if somebody's already got a slight degree of dementia or cognitive change, they can go into a downward spiral. But in a young person, because your brain is normally tight inside your skull, and normally it fits like a crash helmet, a subdural has really arisen through some nasty tearing of the brain, and is often associated with diffuse axonal injury. And that is, if you like, a sign of a severe injury. So you've got a young, fit person who has a subdural. That's a far more significant injury and is likely to be associated with other areas of damage. Diffuse axonal injury is basically traction, rotational injury to the fibers of the brain. It's generally sign of quite severe damage, acceleration, deceleration. It's classified 1 to 4. It's generally a diagnosis that was traditionally made at post-mortem. So it's always a little bit I think controversial in terms of making the diagnosis. There are various scanning techniques. Somebody who has very bad diffuse axonal injury will show up in terms of, even a CT will show loss of white grey matter differentiation. An MRI scan will show significant changes. There are a few people for whom they perhaps have some subtle damage that doesn't show up on conventional MRI, and 3 Tesla diffusion weighting MRI has been shown in research to pick up some of these subtle aspects of the diffuse axonal injury. Again, I think it's difficult because lawyers like to make a lot of scan results because it's real or not real, whereas in reality, what's real is real to the patient. Yeah. And I think that certainly in clinical practice, we don't necessarily do 3T for this particular indication. There are some uses in stroke care in clinical practice, so it may become more available. But really, those are the nature of the damage. You can also get focal bruising called contusion of the brain, and that's of significance insofar as it can be a focus for an epileptic focus later on in life. It is also very, from your point of view, indicative that there has been an injury for the brain, and you are typically going to meet people from a lawyer's point of view who have had a loss of consciousness. They may well have had a period of post-traumatic amnesia, and they may well have had a period of time where they have had concussion symptoms afterwards. But there will be a group of people who continue to have ongoing cognitive symptoms, which are ostensibly out of proportion to what may have been the index injury. And that is a group of people I think you see quite a lot, where you're trying to get to the bottom of where things are, really.
I think it goes without saying as well, there's not just sort of scanning techniques and in ways of identifying if there are executive functioning issues. There are, of course, sort of neuropsychometric testing which can pick up on those issues.
And I think that's the honest truth, is actually it's how the brain functions. I think, we overstate the importance of imaging, because the brain is a living, breathing thing, if you like, that functions, and it functions in a biopsychosocial mode. And if we take the hypothesis that emotional experiences affect how the brain functions in a very physiological way, you can see how complicated the situation actually is, and how erroneous it is to over simplify the situation.
Can you sort of explain what happens to those damaged axons and neural pathways?
Well, I mean,
are they permanently broken?
Yeah. I mean, what tends to happen is that as these neurons are disrupted, they tend to release neurotransmitters, which are their chemicals. Those chemicals can cause a cascade of damage to the various pathways, because they will stimulate other cells, and those cells will activate and burst, and you get a lysis, you get a toxic response, you get swelling of the brain, and that's indicative of damage. One of the areas in which people will have neurosurgery is if the brain do swell, they would have a craniotomy, even if there isn't blood, or a craniectomy, where they'll take a bit of skull away. And that can happen because there is a life-threatening rise in intracranial pressure. And this is one of the areas in which they get monitored, full stop. I mean, to be honest, at this stage, it is down to the neurointensive care. This isn't really a rehab medicine area, really. At this stage, by the time you receive people, they will have received neurointensive care, but people may well have had very, very significant injuries. And it's also worth saying that different people can have an injury of apparently similar severity, and some people will get a rapid rise in intracranial pressure and a lot of secondary damage, if you like, and other people will do better. There's some consideration as to whether there's certain genotypes, ApoE expression in people's genes. Sometimes it's to do with thinking about age.
That was really good to hear about all of that, Ruth, in terms of I suppose the diagnosis and what the various functions of the brain are. I think it is important to do that, albeit it's quite academic. I think what I really want to get our teeth into now is something that you're quite passionate about, because it is your job, and that is about following that acute hospital treatment, neurointensive care that that individual will receive, is what happens thereafter in terms of the rehabilitation and the role that can play in combating the difficulties that individual will face.
Brilliant. Well, that is exactly right, because I think the question next is, what value added does rehab add to recovery? Because I think it's important to think about what is rehabilitation. And if you look at some of the basic WHO definitions of rehab, it isn't just about physiotherapy, and it isn't just about recovery. It's about using all possible means to get that person to back with where they were before. And that can include both interventions for the person and interventions for the environment around them. Now, the best model to think about is called the ICF, or the International Classification of Function. And that basically would talk about structure and function of the body, which could be cognition, it could be mobility, it could be a number of different, if you like, impairments, as in old language. And then you talk about activity limitation, somebody's ability to conduct social conversation, their ability to mobilize in their community and negotiate their community, their ability to perform their activities of daily living, and that's activity limitation. And then you talk about participation restriction, which is your ability or otherwise to fulfill your social roles. And actually, when it comes down to it, that is what you are looking for in terms of rehabilitation. Unfortunately, in popular culture, I'm sad to say, most people think walking is incredibly important. And if you can walk and talk a bit, then you must have made a good recovery. And I think one of the difficulties with rehabilitation is about having this honest discussion about the fact that the thing that makes a big difference to somebody of quality of life long term is their ability to fulfill their social roles and to do those things that give them pleasure in life and to fulfill their relationships in life. And I think when we're thinking about rehab, we should be very focused on it. Now, I'll be honest and say that there are therapists who probably do think quite similarly. And there are therapists who feel that if you go to the nth degree, and while you can still find things to work on, you need to keep working at things. And it is fair to say that there is evidence to say that the volume of practice makes an impact on therapy and improvement, as does early treatment. And when you're looking at the early stages of rehabilitation, much of your rehabilitation is going to be impairment based. So you are, for example, going to try and reduce physical or cognitive complications of the injuries. So in the very acute phase, you would want to prevent somebody developing, for example, muscle contractures, shoulder subluxation. You might want to prevent them developing pressure sores. You might want to prevent them developing infections. You might want to prevent them developing pain. You might also want to prevent them developing behavioural problems. So lots of early rehabilitation is around stabilising the physical condition and improving the period of acute recovery. And that is, if you would call it, neurological plasticity. So what you're looking at is trying to put in place the best possible conditions to be able to enhance the natural neurological recovery. One of the things you notice is that people become very deconditioned very quickly. You know, if you're ill for a week, you realize how much weaker you are. Imagine if you're ill for 3 months, just how weak you are. And a lot of early interventions around physiotherapy, it's around building up stamina, fitness, and actually looking at being able to restore normal patterns of movement in the future, which will prevent complications. So in the very early phase, you are looking at rehabilitation on the impairment level. So you may be working on somebody's speech at an impairment level. You may be looking at arm function, lots of practice. This is a part of rehabilitation where there's a lot of excitement, looking at how we can practice things early. So, for example, treadmill-assisted training, functional electrical stimulation during movement, treadmill training with a suspended parachute harness, virtual reality type treatment. So lots of interesting areas where people are interested in trying to get early functioning back and to try and avoid the inevitable deconditioning. So you can see that some very early impairment-based rehabilitation is really helpful. And because volume of practice is relevant, I have to say that we get a lot of issues on the ward with families saying, you know, this is terrible, they're only getting an hour of physiotherapy a day. And actually, really what you need to do is to run a rehabilitation ward, a rehabilitation unit in such a way that people are rehabilitating constantly. So everything that they do in their day with their nurses, in the structured day, with the rehab assistants, with worksheets, with work files, is actually aimed around rehabilitation. And I think the early challenges is about delivering the intensity of rehabilitation. But then once people get home, part of the transition to home is having a look how somebody adjusts to their new degree of impairment or disability, and does adjust to how they manage in the home environment. And in the early stages of rehabilitation, people are often very hopeful, and they are very much around, well, it's all going to go back to normal, everything's going to be fine. And people can have sky high expectations. And psychology is incredibly important in these early stages to put in place those knowledge, expectations. And I think it's really, really important to both improve people's knowledge and to manage their expectations. Because I think, people perhaps are very grateful that they're going to survive, and then suddenly, they have to adjust to life at home. Going home, I think, is a massive issue, and I think it's a big step into the unknown, and most families are really quite scared when somebody goes home with a disability. Often patients, if they lack insight, can often say, doctor, I need to go home, I want to go home. And what they mean is they're not happy where they are now and they want to be in a place of safety. But that is a difficult situation, because how do people manage? And I think sometimes the reality of rehabilitation is really that people don't realise the extent of their life changes until they get home. And when you're picking up people, perhaps as part of the litigation process, because sometimes you're lucky and you pick people up in hospital or straight out of hospital, and you can commission post-acute rehab, you are in a good position to be able to support the situation. But often you're picking people up and they're a little bit down the line. At that stage, I think what you're looking at is actually looking at, first of all, what is this person's disability? What is their impairment? And the first thing you need to do is to get a really good, accurate assessment of their disability. And also be mindful of what the underlying pathology is. And one of the problems, I think, in legal reports is people can have the wrong diagnosis. So somebody can meet a case manager, for example, and they can be very affected by their condition because of a mixture of psychological as well as physical issues. And their case manager can say, oh, they've got terrible brain injuries and what have you. And you go back to the medical background, and it's very evident that the person has had a relatively modest organic injury to the brain, but they have got major psychiatric comorbidity, they've got major psychological comorbidity, and therefore the right formulation is absolutely essential. And I can't really overestimate at this stage the importance of having good, accurate assessments of what's going on, because I think it saves a lot of heartache, I think, later on.
I think we've both seen how, when an individual goes into the community after they might have had good acute care, good post-acute sort of rehab at a centre somewhere, and then they're sort of left to fend effectively for themselves in the community, and that sort of and their recovery can sort of then to drop off a little bit. And
exactly.
In some circumstances, they're fortunate they might have someone like myself as a solicitor to then explore private provision through a claim. But there's some that don't, unfortunately, and that's often a battle. But I think just talking about, you mentioned there about having a good initial assessment in terms of the community functioning. In your mind, Ruth, what works well in terms of a good case manager, multidisciplinary team, working with someone in the community? What needs to be done there?
I think, first of all, there needs to be, a really good rapport with the patient and the family. I think that is absolutely essential. I'm always concerned if I do a medical legal report and the person can't remember the name of their therapist.
Yeah.
To me, that is somebody who thinks they're going through the motions, and that's not, and I think when somebody's got a really good relationship with the case manager, and it can be difficult because sometimes people haven't got the time. I think so that's definitely important. I think the second one is time to get to know the person and the person they are, and what the goals are, and actually what they are going to do with the rest of their life. Because I think there is a big mistake, and certain therapists, and I sound like I'm being critical here, but there are therapists who can become very focused on the micro detail of certain aspects of impairment without answering the big picture of what is this person going to do with the rest of their life.
Yeah.
And I think that everything has to be in the context of the holistic big picture of the person. So it's really important. So this person may have been a worker, a parent, a partner, somebody who had this hobby. This is somebody who did this. And in my view, what can happen is, for example, somebody could, for example, really improve because they still have a degree of plasticity. So, for example, somebody who is having problems with their speech, ongoing speech therapy around enhancing their communication skills and training up their family to understand their communication skills and to build up the family's communication in a really holistic way is going to contribute tremendously to their quality of life. And it may even be a couple of years down the line, but you are really going to work on the picture, and you're going to work on all aspects of the big picture. You might, for example, get somebody who has a physical impairment, but they're just incredibly deconditioned, and working with their physiotherapists to work on, yes, their movement control and their balance, but also their conditioning in a very holistic way, taking physio sessions into the gym in between sessions, so somebody's building up their stamina. Again, that's a very holistic way, and some of the best physio providers actually work out of their own private gyms, and that works quite well because it's about volume of practice. It's not about one physio arriving, visiting you once a week, and then you sit watching daytime TV the rest of the week. And looking at that holistic approach is important. Things like occupational therapy I find really important, because I think they take a very holistic view naturally. They will look at work, they will look at day-to-day activities, they will look at the broader picture of how somebody's home is adapted and equipped. Having somebody in the correct built environment is really, really helpful. And I know people talk a lot about housing, but I would say that the right environment for that person, so that person can negotiate that environment as independently as possible, is going to be beneficial. It's often a very good early win, early consideration. So looking at these things holistically, I think, is really important. And another way which people will often look at things holistically is to employ somebody like a rehabilitation assistant or a support worker that actually provides therapy intervention.
Yeah.
There are people who, for whatever reason, aren't safe to be left alone, and they will have a needed degree of supervision. But putting in a carer isn't a thing. That isn't rehab.
Yeah.
Putting in a carer who actually does things according to the book and keeps really good notes and really good observations and is a really good witness is actually what you need. And I think getting that idea of the bigger commissioning a big picture rather than little snippets of pictures.
And I think that's why it's important if we looked at this through the lens of personal injury litigation, and you've got the advantage of having a case manager. It's really important to have a good case manager, which is something we'll talk about in a different episode where I do actually interview a case manager, and they will talk about what makes a good case manager. But they should really be the individual you're, I suppose, referring to, Ruth, in that they have to take that holistic view, not get bogged down in the minutiae of this and that, and like you say, look at the bigger picture and where is this program being driven towards? Is it aligning with what that individual wanted in terms of their recovery? I think you'd probably agree with that in terms of the case manager role.
Yeah.
What I wanted to ask you next about, Ruth, was we've spoken a bit about the rehabilitation process, particularly in the community, and like I said before, it's something you're particularly passionate about. In your career, can you sort of pinpoint a particular highlight, if you like, with maybe in one or two individuals where you've seen them sort of from day one, in a really poor position, but have made something of themselves thereafter?
Yeah, I mean, it's absolutely lovely when you do see people over a period of time. Obviously, there are people who have conditions which will improve, and that's always really nice. For example, you can see somebody in the early stages of a stroke, and because they are continuing to make improvements as their viable neural tissue comes out and they can do more and they can build up. I think, that's absolutely lovely. And it's really nice when you see somebody who goes through, gets back to work, goes to, is able to drive, able to resume their family life, and basically adjust to their disability. And I think one of the things that you have to do is to take comfort in the fact that there are people who remain disabled but are living a very worthwhile life, and they are not living a life which is poorer in quality than it would beforehand. And I think that is really what the ultimate goal. I mean, I'm thinking of one lady who retrained as a counsellor, and she works as a counsellor in prisons, and yet we still have to see her around her Botox. We still have to we had some problems with her developing epilepsy and what have you, so she's not without health issues, but fundamentally the contribution she is making to the world, having been on a very quite a dark journey, is very good. I mean, I suppose one particular young couple always sticks in my mind insofar as there was one young couple who were both separately in severe road traffic accidents, severe brain injuries. The young lady actually was in a car with 4 occupants, of which one died and 3 became severely disabled. And I can't imagine what the insurance bill was on that Ford Fiesta, but I imagine it was multiple times exactly above that. And I stayed in touch with her simply, I think, because she was local to me, and she was very, very severely injured and is very, very severely impaired, and cognitively has, significant issues with her memory, significant issues ongoing with her communication, and, is significantly disabled, but still has sufficient personality that she is herself, and sufficient determination, and sufficient positivity, and her very, very nice family who provided a huge amount of support. And interestingly, she met another young man who was injured also at the age of 17. He's a little bit older than her, and And he also had recovered from his brain injury such that he was walking wounded, but they met at a headway group, and they've gone on to have a young son together. And because of the resources available from her litigation,
Yeah.
you know, they've had that sort of happy ever after, as far as that is, you know, is possible, you know.
Yeah, that is that quality of life, isn't it? That's what I say.
It is quality of life. But the thing is, it isn't happy ever after, like the problems went away. You know, and because of the contingency for ongoing therapy, for ongoing care, the fact that they can get back under medic when they need it, the fact that there is that support there.
Yeah.
You know, it is not, you know, I wouldn't want to romanticize living with a disability. Living with a disability is actually a nuisance, you know, but it is a nuisance rather than something that, you know, my life is ruined. And I think helping people to move away from this sense that my life is ruined, I think is really, really important. And I think one of the ethical things for me in the medical legal process is how much of the narrative around medical legal processes is around preparing information that says that somebody's life's been ruined.
Yes.
And it's not helpful. It's not helpful for anybody's soul, let alone anything else. And I think how we manage that is really, really important. And I think, you know, my life is different, but I can't say it's worse. It's probably what a good outcome of what you as a legal team are trying to achieve. And if you can put your hand on your heart and that's what you've achieved, then you've done a really good day's work, haven't you?
Yeah. It is. It's just about getting that person as close as they possibly were to where they were pre-accident from our perspective as lawyers, of course. I mean, it's sort of, you sort of answered one of my other questions, which is, you know, some people who are watching or listening to this is, you know, how long is the rehab process? Well, it's a continuing, evolving process.
It is, and it is an interesting thing. How long is the rehabilitation progress? I mean, when you are looking at early degrees of plasticity, people talk about the first 2 to 3 years, although language perhaps goes on for longer. In young people where there's still a degree of plasticity, recovery because of underlying neurological plasticity potentially goes on to the age of 25. But I think what is really important is to make that distinction between the idea of looking for further recovery and looking for actual rehabilitation. And I think one of the criticisms of the private practice is that there will be therapists in private practice who would continue working with somebody forever. And in many respects, I think we'd all benefit from having our own personal psychotherapist, our own personal physiotherapist. We call them maybe a personal trainer, but you know, there are, you know, it is not to say that there aren't benefits, but there comes a point at which, what are you doing it for? What is the benefit? Are you maintaining? And there's nothing wrong with putting in place a program of maintenance with periodic refreshment plus troubleshooting when there's problems. You know, that is a really good contingency to have, and I have no particular problem with. What I would have a problem with is endless impairment-based rehabilitation, which are making marginal gains that are not, you know, somebody who's having a visit from the physio every week, but it's not making impact, so you couldn't measure the impact on their life.
I think
would be, I think, hard to justify.
Yeah, that goes back to the point you made earlier, isn't it, Ruth, about not being bogged down in the detail and looking at the bigger picture and things of that nature.
On the other hand, if you've got somebody who has a disability who gets taken to the pool twice a week and maintains their degree of muscle strength, they don't fall, they control their falls risk, they maintain their cardiovascular fitness, they maintain their muscle strength because they're on a sensible maintenance program
Yeah.
and it's periodically refreshed, definitely that is a good benefit. So you can see it's about, from your point of view, it's about drilling down about what you're actually paying for. And I think it's about having that dialogue, I think. And I think the skill, coming back to your case manager, it's the skill of having those dialogues about what are realistic options, really.
So no, that was great, that, Ruth. Really appreciate your time.
Thank you.
Talking through the mechanics of the brain. Appreciate that can be a little bit dry and academic, but I think for viewers and listeners, it is important for them just to get a bit of an understanding what's going on in the school there, but also just hearing about your thoughts and views on rehabilitation generally. That was fantastic. And yeah, thanks very much for your time today, and we'll speak soon, I've no doubt.
Thanks very much.